have Dr. Kim Tartaglia. She is a professor of medicine in the Department of Internal Medicine. In addition to internal medicine and pediatrics, she is board certified in health and wellness coaching and lifestyle medicine. Her patient care interests are focused on using lifestyle to prevent, treat, and reverse disease. So please join me in welcoming Dr. Kim Tartaglia.
Let's see if it works.
Oh, wait, so we can tell it works.
Yeah. Okay. Thanks for having me. I have to stay on the slide for just a second so you can see my heart hands. I can strongly recommend the Health Athlete Worksheet, our workshop. I did that pre-COVID and really liked it. This is really an overview of a lot of things that can promote heart health or cardiovascular health. So I do welcome any areas you want to dive deeper into. We should have time for that. So we're going to talk about the symptoms of cardiovascular disease, as well as the risks and things you can do to be proactive. And when we think of cardiovascular disease, it's really anything heart or blood vessel related. So it's like a whole fellowship. But we're going to talk mostly about atherosclerotic cardiovascular disease. And you could see that we often think about heart attack, but it's not just heart attack. It's stroke. It's the symptoms of not getting enough blood to your heart or your lungs, so it could be shortness of breath, or not getting enough blood to your spinal arteries, for example, something like a spinal stroke, or what we call peripheral arterial disease, cold hands and feet, or inadequate blood flow to your extremities. But one thing people don't often realize is that something as common as erectile dysfunction is often a symptom of cardiovascular disease. So if you're a man or you know a man, they might be interested in protecting their cardiovascular health for a lot of different reasons. And we know it's common. It is the #1 killer in the US and across the world. And it gets more common as you get older. So, we don't see a ton of clinically significant cardiovascular disease in those people who are in their 20s. Although if we have people who die for other reasons, like a car accident, when they do the autopsy, they see early cardiovascular disease already starting. And then if you think about cardiovascular deaths all told, just heart disease and stroke alone are 60% of the deaths in this country. In case you don't know, I think there's been a good public campaign about what are the symptoms of an acute cardiovascular event. So for stroke, this is, thinking of a blockage in one of your arteries going to your brain. We think about the fast mnemonic. So face, is there weakness or drooping of the face? A for arms, is there numbness or weakness of an arm or an extremity? S is for speech, is there slurring of your speech? And then T is for time, in that this is an acute event that you want to seek medical care for urgently. Similarly, for heart disease, like a heart attack, we often think about that chest pain or pressure, but know that women tend to have atypical symptoms. People with diabetes tend to have atypical symptoms. And so it could be dizziness, it could be flush, like paleness or diaphoresis, a little bit of sweating, it could be nausea. So my brother unfortunately needed a heart stent at age 43, and his symptom was indigestion, but it was indigestion when he was trying to play soccer with his sons. And so he hadn't and not when he had recently eaten. So anything that's brought on by exertion, activity, or exercise could, even if it doesn't seem like a symptom of a heart disease or cardiovascular disease, it might be, because indigestion was his symptom. It could be difficulty breathing. And then unfortunately, cardiac death is still all too common, the first symptom someone has of a heart disease, because if you have sort of an acute event where you don't get enough blood flow to your heart, it could make the electrical rhythms a little wonky and cause your heart to stop completely. And then symptoms of peripheral arterial disease. These are things like aching when you walk, loss of hair or shininess of your skin, ulcers or wounds that won't heal. And often that can happen if you have diabetes and the small blood vessels get impacted. Or it could be an acute event. So more often than not, peripheral arterial disease does not give you acute symptoms like an acute blockage, although it can. It's this gradual loss of function and muscle and hair and skin in your legs. It's important to know what is happening at the sort of anatomical level. When I think of healthy blood vessels, I think about the lining of the blood vessels. It's a layer of cells called the endothelium. It's really important that those are slippery and those are relaxed and happy. A lot of kind of relaxation chemicals are sort of in that milieu, because we really only want our endothelium to get sticky when we've cut a blood vessel, right? If you have a cut, you want to be able to form a scab and clot that off so you don't continue to bleed. But what happens in atherosclerotic disease is, for many reasons, whether it be smoking, high blood pressure, inflammation from any cause, our endothelium can get sticky. So that's a problem, especially in the acute setting. But what's happening sort of more chronically is this buildup of plaque, predominantly cholesterol, but other chemicals that form this sort of narrowing of the blood vessel. And if you have, most of the heart attacks happen not when you're 90% narrowed, but when you're 40 or 50% narrowed, because those are what we call unstable plaques. They haven't calcified and hardened, but rather they are just kind of this like soft plaque that is a little more vulnerable. And if you put inflammation on top of that and you get sticky endothelium, then suddenly your body wants to form a clot there because it thinks there's an injury there. And that's when the acute heart attacks happen. So you can think about, the acute problem versus the chronic problem. Both of them, I think, use a couple of common denominators that we can get to the bottom of. I think it's important to talk about risk factors, and we can divide them into non-modifiable risk factors, things we can't change. But there's not a lot of utility in talking too long about that because, let's focus on what we can change. So non-modifiable risk factors, age is a risk factor for most diseases, as is gender. So men are affected, as you saw in that graph, more often than women, but that changes once women hit menopause and become postmenopausal, in part because women are living into their 80s, but they're still going to ultimately die of their heart attack. But often the loss of those protective estrogens, that are diminishing into menopause helps like even the playing field. Genetic factors, and those could be things like familial high cholesterol, or something called Lp(a) I'll tell you about. It's also genetically determined how we tend to distribute fat. So some of us, I think, are more of that pear shape where we put our excess fat. We all have fat on our body. That's normal. It's healthy. If we put it more on around our hips, it tends to be less inflammatory and less cardiovascular disease promoting. But if we have that genetic predisposition, men, I think, are more like this too, but even some women, where you tend to put more of your fat, your excess calories in your stomach around your organs, that is an inflammatory environment that it's creating for your blood vessels. And so we don't have a lot of control over where our body tends to put excess fat. And that's why I think when they look at the BMI calculators, which have, some pros and cons, for people of Asian ancestry, the BMI normal values are a little lower than the rest of us, because if you're of Asian ancestry, you might be more likely to put your fat more in your belly, in your viscera. And that's kind of that race ethnicity part of it as well. Then we'll talk mostly about these modifiable risk factors: high blood pressure, smoking, development of diabetes, physical activity or inactivity, obesity, and high blood cholesterol. We can do things about this. And we'll talk more moving forward. Lp(a) is something that if you have a family history of heart disease, if you have a family history of, inherited high cholesterol syndromes, if you have someone in your family has an elevated Lp(a), that might be a reason to ask your cardiologist or ask your doctor to get checked for. It's something you only need to be checked for once, because if you have the genetic variant for a high Lp(a), that's a risk factor for you for cardiovascular disease. Lp(a) stands for lipoprotein A, and it's just some of us have a genetic variant. I haven't gotten my test yet because I'm waiting for my next blood draw. But do you have a predisposition to have high levels of Lp(a), which contribute to plaque formation in your blood vessels? And if you have this, you're higher risk for cardiovascular disease, including things like aortic stenosis and stroke. So it's just a test you get done once. There is no true treatment for this, but other than cleaning out your blood like you would in a dialysis type fashion. But they are working on studies to look at medications directed to this. Otherwise, the best advice, the reason to know if you have a high Lp(a), which is higher than 125 if you're doing nanomoles, is because you're going to work extra hard to get your cholesterol numbers down even farther. So your targets might be even more aggressive. And you would do this, have this conversation in context with the cardiologist. The prevalence of modifiable risk factors you see, again, these often don't live alone. They travel in groups. If you have obesity, especially, abdominal obesity, you're more likely to have high cholesterol and diabetes. We talk about metabolic syndrome, which I'll mention in a minute. But you can see these are getting increasingly prevalent. And I had to change the number on this slide because I think this was data from maybe 2018, and our diabetes incidence and prevalence has gone up. So now about 11%. So when we talk about targets, I don't know, has anyone done their biometric screening for this year already? Great. So one thing you'll measure is a non-HDL-C. So that's a non-HDL cholesterol or LDL cholesterol. So our guidelines are based on LDL cholesterol, but those are essentially measuring about the same thing. Some people might hear influencers talk about an ApoB. It's apolipoprotein B. Again, also measuring about the same thing. And so hopefully the podium isn't blocking you, but here are the targets, and it will say anything under 100 is optimal. And I would say that if you don't have cardiovascular disease and you're under 100, that's a good sign. But if you do have cardiovascular disease, that's certainly not enough. And we know that there are populations around the world where heart disease and heart attacks are essentially non-existent. Their LDL cholesterol is somewhere between 40 and 70. And that is our target for people who have known coronary disease as well. So we call that secondary prevention. Your LDL-C target is also less than 70. And I would say that's a truly optimal level for all of us. You can get there without medications unless you have an inherited condition. And if not, then you may need medications to help get you there. Same with the blood pressure targets on your biometric screen. Less than 120/80. I think we all know those numbers. And it is, sort of progressively worse prognosis the higher you are. So if you can't get it to 120/80, get it as close as you can. And if you're sitting around at, 105/70, there's really no blood pressure that's too low as long as you're, not in an acute illness, an acute infection, and you're not having symptoms of dizziness or lightheadedness passing out. For our blood glucose targets, we think about, again, thinking about risk factors. This is what we measure when we're thinking about diabetes. We often measure a hemoglobin A1C. So that biometric screening will measure something called a glycosylated hemoglobin, which is the glucose attached to your hemoglobin. And it's really just a natural process that happens over time. And so our blood cells live about 3 months. And so checking a hemoglobin A1C, every 3 months for people with diabetes is why we do that. But we check it once a year if you don't, and you're looking for something in that normal range, which is considered less than 5.7. So anything between 5.7 and 6.5 or 6.49 is considered pre-diabetes, and 6.5 and higher is considered diabetes. Again, lower is better until you get to a really low range. But most of us think that, if you're hovering around 5.5, 5.6, you don't technically have prediabetes, but that's not quite optimal. An optimal range would be in that, 5 to 5.4 range. So it's just to say that, if you want the lowest risk of heart disease possible, know that sometimes our cutoffs for normal aren't getting you the absolute lowest risk you can. And depending on where you have some work to do, that can sort of prioritize your areas of focus. Just to kind of come back to the concept of obesity and metabolic syndrome. So metabolic syndrome is really a collection of findings we see that tend to have higher levels of inflammation, higher levels of chronic disease, higher levels of cardiovascular disease. And really, they're not focusing on BMI, as you see here, they're focusing on abdominal obesity. And the only way to know how much visceral fat you have is really with something called a DEXA scan, a body composition test. But a nice inexpensive surrogate is to measure your waist circumference. And so less than 35 inches in women and less than 40 inches in men is what we're aiming for. If you have a combination of high waist circumference and high triglycerides, which is a measure of our blood fat, or a low LDL cholesterol, HDL, or high blood pressure or high glucose, you just need 3 of those to kind of meet the criteria of metabolic syndrome. And this isn't a disease so much as like a description of maybe what's happening in your body of poor metabolic health. And so really the treatment is to focus on these, kind of getting these numbers more in the target range. Questions on that before I move on? So when we think about, those are the numbers we look at that really drive our modifiable risk factors. It's, I think, important and empowering to think about how can we change our risk for cardiovascular disease, because it doesn't have to be the #1 killer in this country. And as was mentioned in the introduction, I have training in a specialty called lifestyle medicine. And what I do clinically now is I see patients in the hospital and do a lifestyle medicine consult for them. So most of the patients I'm seeing are in the Ross, cardiac surgery patients after they've had a bypass, or cardiology patients after they've had a stent. And I'm doing an assessment of their lifestyle, breaking it down to 6 pillars. And each one of these, I would say this talk, I could probably, take most of these slides and embed them in almost any talk I give on lifestyle medicine, because the beauty is that the lifestyle factors that reduce your risk of cardiovascular disease are the same lifestyle habits that reduce our risk of diabetes, of cancer, even potentially autoimmune disease and depression. So this is not necessarily so narrow. If there is something that's very specific, I will point it out. But the 6 pillars we focus on in lifestyle medicine is nutrition, focusing on a whole food, plant predominant diet, getting regular activity, getting restorative sleep, avoiding risky substances, connecting with others in our community, and also managing our stress. So we'll take each of those in turn. No one here needs me to tell you that you shouldn't smoke, that it's not contributing to your health. And specifically, this are the risks that you're taking on when you're talking about cardiovascular disease: up to 4 times more risk of heart attack and 2 times risk of smoke. Vaping is not safe in regards to cardiovascular disease. And so if you need help, and when I'm talking to patients, if smoking is sort of one of the things that we identify as a priority, it's usually the top priority, because you're not going to recover from your CABG surgery, your bypass surgery, if you smoke, and you're putting yourself at risk for another heart attack. I apologize, this got jumbled in the handout. Alcohol, I think, is one of the tricky things. We do know that any alcohol intake increases our blood pressure. So if that's a problem for you, might be a reason not to drink at all. It also increases our risk of something called atrial fibrillation, which is an electrical abnormality in the heart. Or tachycardia just means fast heart rate, or cardiomyopathy. But there are some mixed studies, and you'll see in some of the dietary pattern recommendations that low amounts of alcohol are probably not detrimental for heart health. I think if anyone says, avoid alcohol completely, the main risk it's driving is our cancer risk. Even low levels of alcohol for some cancers can increase the risk. But for heart disease, I can't tell you, oh, don't drink because it's bad for your heart, if you do it in low amounts. Once you get higher, again, in addition to increasing your blood pressure, you're going to increase the inflammation in your body, and you're going to increase your cholesterol levels, and it will increase your risk of atherosclerotic cardiovascular disease, as well as we have alcohol-induced cardiomyopathy, which just means that your heart muscle doesn't pump well. And it's because alcohol is a toxin, and so it can be toxic to the heart. And some people are just more prone to it than others. So just a reason to just be careful about alcohol use, and probably not say, we're drinking for our health. All right, let's talk about stress. I'm doing nutrition and exercise last because that's the one that will get me over on time if I'm not careful. So let's talk about stress. There's a great book by Vivek Murthy. He is our US Surgeon General, about loneliness and the epidemic of loneliness and social isolation, despite being so connected on social media. And as we come out of, isolation from COVID, we know that pre-COVID, post-COVID, isolation and loneliness are associated with higher stress hormones, higher inflammation, higher blood pressure. So just from a cardiovascular standpoint alone, it's not great. And this NHANES 3 study that looked at a ton of women, a large study with women, looked at kind of a low social network, low connectivity with a social network, was as risky as smoking or having high blood pressure as far as overall mortality. That wasn't specific to cardiovascular disease. So thinking about that, being alone is not the same as being lonely. So it's okay if you're an introvert and you like your time by yourself, but that true loneliness and being honest with yourself, like, do you have people you can call in the middle of the night? When I see patients in the hospital, I say, what 3 people can you call when you really need something? Where it's like, you don't owe them a favor. They're going to pick up the phone and they're going to help you no matter what. And it's kind of a sign to me that if they can't name anybody, or they can't name 3 people, that I'm concerned. And we know the negative consequences of stress. I think I don't have a slide for this, but also just I often ask patients about their purpose and their meaning in their life. So having a reason for living and a reason for waking up, especially as I see my retired patients, it's so important. And again, stress in general, not just loneliness, but stress of any kind. We know that it increases our risk of cardiovascular disease. It increases our blood pressure, and it increases our inflammation, amongst a number of other things. So it's worth addressing. But this is the hardest one for me to give you like some tips, because stress management tips just sound kind of trite. I don't know your situation, and so I don't know what's actually driving your stress. It might be financial stress if you have trouble, paying your health insurance bills, your health bills. It might be childcare stress. So this is from betterup.com, and it just kind of talks about, there are some strategies we can do, and we're going to cover many of them otherwise in the lifestyle pillars. But in the short term, if you're having acute stress, can you do some nose breathing exercises, which I had to do before coming up here because the anxiety or the amping up of just coming to talk to you, taking a walk outside, aromatherapy, like you can try these things to see if they're helpful. And then just thinking about where is your stress coming from, home, from a relationship, from work, and addressing it. So when I talk to patients about this, it is definitely a very personalized, tailored approach. And since we're here talking about sort of wellness at work, it's worth just, mentioning kind of like this, this need to continue to advocate for wellness at work and to make sure that it's not unnecessarily contributing to our stress. There's a difference between what we call youth stress or good stress, the stress of giving up and giving a talk or doing something that gets you outside your comfort zone that's good for us and luckily doesn't have long-term negative effects. But that distress, that negative stress that's weighing on us might be coming from work. The culture of work, we don't recognize people when they do a good job or when they're trying hard. We don't, give them resources to grow and develop. We don't, give them what they need to do their job and do their job well. And so this is really what I think Buckeye Wellness innovators, have tried to promote is like in your areas, how can we help you be well? It is good for your heart. So sleep. So interestingly enough, and I didn't, for the sake of time, pull up the studies, but as we go forward and think about daylight saving times and we spring forward, it's one of the highest risks of heart attack, that day or two, 48 to 72 hours after that. And that's because that loss of sleep can be what tips you over the edge, just like shoveling a heavy driveway. So get your sleep. And if you need to work back with the clock to get to sleep earlier, the couple days before we change our time, do that. From sleep.org, I think we all know that at different times of our lives, we need different amounts of sleep. The dark blue is really the ranges that most people need to be healthy. I tend to be on that 8 to 9 range. I wish I was more on that 6 to 7 hour range, but it's just not there. And so, just carving out time for that is so important. Of course, we want it to be high quality sleep. Because if we don't get enough high quality sleep, we know that in the short term, it affects us just one night. We're more irritable. We have no impulse control to stick to our healthy eating plan or to exercise. We have no patience for our children or our spouse. And so, that's not good. But then long term, again, cardiovascular disease, you can see these are all the modifiable risk factors I've talked about. And so many people believe sleep is really the foundation of everything we do. If we don't get sleep right, then that's what we need to focus on first. And it can be difficult because is it anxiety impacting your sleep? Is it work tasks or home tasks impacting your sleep? Or have you set up an environment that is not conducive to sleep? And that's, I think, the easiest thing to fix. So this didn't come through quite like I have, but I think this is so fascinating. I'm not a sleep doctor, but there are really two things that drive our sleep. Our circadian rhythms here, about a 24-hour cycle. It is modulated by melatonin, which, comes from the pineal gland in our brain. And so it's about a 24-hour cycle that, during the nighttime, we get sleepy and want to sleep. And that's coupled with something called the sleep pressure or sleep drive. And that is the longer we're awake, adenosine builds up in our body. And so once you get to this critical mass of adenosine, basically it's the gap between, high melatonin levels, lowering our tendency to be awake, coupled with a high sleep drive, that's when we want to sleep. And we're going to sleep until that adenosine drops down to a normal level. Unless, of course, you stay up all night for pulling an all-nighter to study for a test or you're on call. And then your sleep pressure goes up and up and up and you feel terrible. So I say this is helpful because when we think about what are the strategies to help you with your sleep, there are really two columns. Is it a circadian rhythm problem that we need to train your circadian rhythm? And so many of our modern day life it's like we're in constant jet lag because we don't have consistent bedtimes. We're not getting sunshine during the day. We're getting highlight exposure at night. So consistent wake up time is the most important thing. Most sleep doctors will tell you, even if you get to bed late, having a relatively consistent wake up time, and even on the weekends, not letting your sleeping time go about more than an hour or so after your weekday wake up time, if that makes sense. So if you normally get up at 6 a.m. on the weekdays, yes, you could sleep until about 7, but if you let yourself sleep until 9 or 9:30, you're not doing your circadian cycle any favors. Getting early morning light, ideally within about 2 hours of waking up, because that sort of trains our body. Like, okay, low melatonin now, and it's going to gradually build during the day. Dim lights in the evening, because if we're exposed to blue light or excessive lights, that's going to dampen our melatonin. And then interestingly enough, while light is the primary driver of our circadian cycle, every cell in our body has a circadian rhythm. And so the circadian biologist at OSU will know this much better than I do, but even things like eating can confuse our body. If you're eating a big meal at 9 o'clock at night, or you're snacking right up until the time you go to bed, your intestinal cells are confused because they think, well, we eat during the day, we fast at night. And so this can be a secondary way to train your system. Not to mention the fact that your insulin sensitivity is really bad as you get closer to bedtime. And then the sleep pressure problem, that adenosine buildup, if we exercise, we build up more adenosine. So that's good, right? Just like your kids, if they don't get enough outdoor playtime, in part, maybe their circadian rhythm is messed up, but in part, they just haven't, gotten their energy out and they're up bouncing around at 9:30 at night. I can tell you that my 10-year-old was gifted a PS4 hand-me-down, and his sleep pressure is not high enough and he's staying up way too late. The caffeine binds to your adenosine receptors. That's why it wakes us up. So if you are a slow metabolizer of caffeine and you drink it at 2 or 3 or 4, that you're not going to get to bed at night. So after 2, not having caffeine is safe for many of us. I'm one of the lucky ones. I'm a fast metabolizer. I can sometimes have it up to 6 and not be affected, or I'm just sleep deprived. I don't know. But anytime we sleep, our adenosine, goes down. So our sleep pressure goes down. So naps can be good, but late in the day naps or very long naps sometimes are detrimental to our nighttime sleep. So if you're having trouble sleeping, look at one of these factors and say, do I see a theme here? The other things that can either promote sleep or sabotage, again, high quality sleep is what we're going for, not just time in bed. Alcohol, even if you think it helps you sleep, it does not give you high quality sleep. And that was hard for me to learn because I thought I was sleeping fine and I liked my glass of wine after my kids went to bed, but I know the science suggests that I'm not. Our core temperature needs to go down when we are going to bed. That's how we help fall asleep. And one way to do that might be counterintuitive, but to take a hot bath, or if you have access to a sauna, or, warm up your extremities because your blood vessels dilate and then your core temperature goes down. We want our bedrooms to be cool, dark, and quiet. Or if you have any noise, like a white noise machine, it's consistent noise. We want to not confuse our brains about what the bed is used for. So it can only be used for 2 things, sleep and the other. If your mind is racing and that's keeping you awake, sometimes the act of getting it down from your brain onto paper tricks your brain into thinking you have tackled that problem, you have let it go, you don't need to keep ruminating over it. So try it if anxiety is keeping you up at night. And then if you can't fall asleep, the worst thing for your sleep is to worry about not being able to get to sleep or to try harder to get to sleep. This is not something where trying harder works. So just get up and do something, ideally not on a screen, and then something kind of boring, quiet activity for about 15 minutes. Hopefully then you'll start to get sleepy and you can come back to bed. All right. So I'm going to talk about nutrition because there's so much studies on nutrition and cardiovascular disease. But really, all the studies, I think I can boil it down into a few bullet points. whole foods, not having ultra processed foods as a bulk of our diet. We know 60% of our calories in the US and some places 70% come from ultra processed food-like substances. So we should stop calling them food. We should call them food-like substances because there's a ton of chemicals in there that is nothing you'd ever find in your grandmother's kitchen or the grocery store. Most of us need to eat more plant foods, and that's helpful for cardiovascular disease, as I'll show you. And what you get when you eat whole plant foods as the predominance of your diet is that you get a lot of nutrients that can be helpful. Things like nitrates that, cause your blood vessels to dilate and not get so sticky or inflamed. But I think we always need to think of food as an entire package. So never saying a nutrient, like just focusing on nitric oxide or just focusing on cholesterol, because you get it as a package. So the studies that have shown kind of the dietary patterns, types of eating that have some evidence for reducing cardiovascular disease include the Mediterranean diet and the DASH diet. We'll talk more about those. A vegetarian or whole food plant-based diet, there's a number of different studies that have called it different things, but can be lumped into that. And then the MIND diet, you might have heard of if you've ever gone to a talk on reducing your risk of dementia or cognitive decline. The MIND diet is just the Mediterranean diet and DASH diet put together. And then again, mostly studied for people wanting to reduce the risk of Alzheimer's. We're understanding that Alzheimer's is probably an inflammatory disease mixed with a vascular disease in a lot of cases, or most types of dementia. So, we could talk about that, but in the interest of time, I'm gonna just focus on the others. The DASH diet stands for Dietary Approaches to Stopping Hypertension. Hypertension is high blood pressure. So this dietary pattern came about because they were noticing people who had a vegetarian lifestyle tended to have lower blood pressures. And so they studied this, and it is not a vegetarian diet because it allows for lean proteins, low-fat dairy, but the bulk of the diet is whole grains. This should say whole grains, and then fruits and vegetables. And they've shown, as I'll show you in a minute, improved blood pressure. It's considered one of the healthiest diets. I think the US News and World Report came out and it was one of the top 2, as was the Mediterranean diet. The Mediterranean diet, it's interesting that, most of the schema, they talk about like how people eat in the Mediterranean, at least classically, they eat together as families, they slow down and have dinner, they don't rush. But really they're focusing here on fruits, vegetables, grains, olive oils, beans and legumes, nuts and seeds, herbs and spices, has some fish and seafood, has little poultry, egg, cheese and yogurt, and very little meats and sweets. And then again, wine gets a lot of play in the Mediterranean and the MIND diet, but I think that probably more so than actually chemicals in the wine being healthy for cardiovascular disease is probably the social nature with which they get together around the happy hour time, 4 to 6 p.m. I think the problems with this is when people hear the DASH diet, I know when I was training as a physician, I thought of the DASH diet as the low salt diet. So, when my patients come in the hospital, if they have hypertension, I'm going to put them on a low salt diet. That is not the DASH diet. Similarly, the Mediterranean diet is not Greek yogurt and fish. It is mostly beans, whole grains, and vegetables. So, I think we can tend to reduce them down to one thing. The Mediterranean diet is also not olive oil. Olive oil is a great part and is a healthy fat, full of healthy fats, but walnuts are just as healthy as olive oil if you want that in your diet. This is a study about the DASH diet, and what you see for high blood pressure, these are common blood pressure medicines. This line here is kind of like if your blood pressure stayed the same with the intervention, and then as you move farther to the left is more lowering of your blood pressure. So you can see blood pressure medicines would lower your blood pressure, that top number, anywhere between 5 to 15 points. If you just reduce salt, it's not that effective. You'll see maybe up to 5 millimeters of mercury decrease. Same with if you just do a DASH diet with high vegetables, whole grains, but also high salt. And if you mix the DASH diet and truly are not having a lot of processed foods, which is where we get most of our salt from, you're going to get an effect better than any blood pressure medicine I have to offer you. And we think what it is the high potassium in those fruits and vegetables and whole grains combined with lower salts because you're not eating a lot of ultra processed foods. There are some studies that talk about, there's so many studies, the Ornish diet, the Esselstyn diet, the Portfolio diet. Predimed was mostly a Mediterranean, and then the Lionheart study was mostly a vegetarian diet. They've all shown improvement in cardiovascular disease, in heart attacks and or strokes. And then there are some that talk about a very strict sort of whole food plant-based diet, which means a plant exclusive diet, no animal products at all. This one, though, I will say, I don't think any of you need to have a plant exclusive diet. But what this has shown us is that for people with very severe heart disease, they're like ready to go to hospice. No surgeon is going to offer them anything. No stents are going to help them. There have been studies both by Dean Ornish out in California and then Caldwell Esselstyn up in Cleveland that show if you totally eliminate any kind of animal products and ultra processed foods, refined grains, and you focus a diet on vegetables, fruits, beans, a little bit of nuts and seeds. They didn't do a ton of fat, and they didn't do a ton of avocado. In this, they were pretty strict. So whole food plant exclusive diet that was also low fat. Not only did these people not have additional heart attacks, but they showed, regression, elimination of their symptoms. Their chest pain went away. When they did angiograms on them, they didn't see nearly the narrowing that they saw before. So, if you have someone who needs to reverse their heart disease and they're really motivated, could they get really strict on this and see remarkable results? Yes. But most of us, one, don't want to do that, or two, don't need to do that. And so I think that's, the message here is that not one diet fits all. You can be really healthy. But we know, again, that too many of us eat refined grains and added sugars and not enough fruits, vegetables, and beans. And so just beans alone, adding 1 cup of beans per day can, on average, increase our lifespan about 4 years. It's, I think, one part that I would love to see added to our salads. All right, so this is the American Heart Association, so the official stance for diet. This is what they say in their language: eat plenty of fruits and vegetables, choose foods mostly with whole grains, choose healthy sources of proteins, and they say mostly from plants like legumes, so those are beans and nuts, some fish and seafood, and this is just showing you that what they don't want you to do is switch to solid plant oils like palm oil or coconut oil. And then you can see kind of avoiding salt, avoiding high alcohol beverages, et cetera. All right, this was a talk from a preventive cardiologist I recently went to, and she offered me the slides. I think it's best to see in the handout, but we've already talked about sort of the top 6 things to avoid, and then the top 6 things she recommends to eat more of. One thing we haven't talked too much about is omega-3s. So omega-3s, we have 2 types of essential fatty acids that we need to make. Essential means your body has to, get them from their diet because they can't make them. Omega-6, we get way too much omega-6 in our diet because that's what is in a lot of oils in our processed foods. So we don't need to worry too much about that. Omega-3s are what we don't get enough of. Can be found in seafood, but high amounts in walnuts, flax seeds, and chia seeds. And then she likes to talk about anti-inflammatory spices and fermented foods, because those, again, thinking about that inflammatory part of cardiovascular disease. I'm going to finish with physical activity before we get to questions. And I left this from another talk, all the lists, the benefits of exercise. There's such great stuff about it's reducing our dementia risk through something called the brain-derived neurotrophic factor, but that's not our talk today. So I've underlined the things where it can help cardiovascular disease. When you're depressed and anxious, you can't live your best life, and you are at higher risk for cardiovascular disease. Exercise is not a good weight loss strategy. It's a good weight maintenance strategy, though. These are the recommendations. I think you probably already know them, but let's talk more about the various types. So has anyone heard of something called NEAT? Non-exercise activity thermogenesis. Think of this as your light activity. NEAT is so important because in the blue zones where cardiovascular disease is almost unheard of, they're not exercising per se. I mean, Brenda's programs to go to the gym are amazing. But if you don't like that or don't want to, in the blue zones, they're not going to the gym. They're just having an active lifestyle as part of their day because they're farming, they're growing their own food, they're making their own bread, they're walking to their neighbors, they're walking to the store. And so a lot of our calories just come from NEAT. And when we try to reduce our calories intake because we're on a diet, or we're otherwise exerting ourselves, or we're trying to lose weight, our body subconsciously does less NEAT. It's like trying to conserve energy because that's how we were evolved. And so you don't fidget much, you don't get up and go, run your errands as much. And so this is why those annoying reminders to park far in the parking lot, or take the stairs, or to set a timer to get up every hour if you have a desk job, even 5 minutes, it really does add up. So I brought this is the hand gripper Sort of hand grip is a surrogate for our strength, but also it's a great way to get some NEAT in for my husband, who I cannot get him to get up from his desk. So, small wins with the hand gripper. Otherwise, you should be able to sing when you do NEAT. Light activities, again, you should be able to put on some music and belt out your favorite song while you're doing the dishes. If you are doing moderate activity, that's something where you can talk but not sing. So grab a friend and go for a brisk walk, and you should be able to have a conversation with them, but belting out Taylor Swift is not something you want to do if it's moderate activity. And then if you're doing the high intensity activity, talking is a little less comfortable as well. So, that's your high intensity workout where you do maybe short bursts of that. Sometimes people make the mistake of doing only high intensity and they never do this light stuff. And that can be inflammatory, especially for women as you're getting menopausal. So just make sure that, yes, vigorous activity is good for you, but in small doses. We don't want you to get hurt or cause more problems. If you're doing nothing, this study and many studies like this, it's one example of just going from doing nothing to doing something, you're going to get most bang for your buck. So over 60,000 people they studied, years of life gained, if you went from nothing leisure time physical activity to an average of 75 minutes of walking per week. So if you're doing nothing now, something is always better than nothing. Everything helps. As you get more and more active, you can see it starts to plateau, so you have less bang for your buck. We don't really plateau until we're doing about 60 to 90 minutes a day. So if you're doing 30 minutes a day and you would like to do 40, you're going to get some added benefit. But if you're doing nothing now and you just get to 15, that's amazing. So these are my top tips for reducing risk factors for cardiovascular disease, and I'll show you some resources. Thinking about the drivers, cholesterol, blood pressure, and visceral fat, which is the abdominal fat. Cholesterol really driven by the amount of saturated fat and trans fats in our diet, as well as dietary cholesterol for a few of us. So anytime we can limit those, which are mostly found in animal foods and processed foods, and instead replace them with high fiber foods like beans, whole grains, and vegetables, limiting the added sugars as well. Blood pressure, we already talked about increasing our potassium, decreasing our sodium, and then the visceral fat, it's multifactorial, but increasing our fiber, and then increasing our activity. It's interesting, people who tend to have trouble with their cholesterol, doing exercise in a fasted state, so you wake up in the morning, you go for your walk, your run, your elliptical, whatever, probably better impacts your cholesterol, has more impact on your blood fats. But if you tend to be more insulin resistant, your A1C is 5.6, 5.7, 5.8, going for a walk after your meals is where you're going to get more insulin sensitivity. And if you have visceral fat, by definition, you have some insulin resistance. So try to get some activity again after your lunch. I'll try to finish early so you can do that. Or take the long way back to work. I won't tell your boss. The other thing is stress. Again, the importance of stress on increasing our cortisol levels and inflammation that drives our visceral fat deposition. Hopefully some of you got handouts. These are just some things I use with patients to try to increase the amount of plants in their diet. We didn't have time to go into gut diversity, how it equates to plant diversity and the plants in your diet. But these are two resources that I find very helpful. This checklist, 30 plants per week, is what we know the healthiest guts in the world get. So 30 different plants per week. So if you want to make it a game, you can. And then this daily dozen are just the types of foods we should, we can aim to get more of. It's not like you have to hit these targets every day, but maybe you'll identify some opportunities. And there's a website and an app that can help you checklist it if that's helpful to you. I share some of these because it talks about cardiovascular risk and the impact of lifestyle. The blue zones, many of you have heard of Dan Buettner, read his books or saw his Netflix special. If you haven't, I think that's what I like about it is it's not just focusing on the food. These two documentaries tend to focus more on food. But Blue Zones talks about our connection with our community, our walking, our active, our reason for being as all really important to our health, including our cardiovascular health. So check those out. Full Plate Living is a program. It's totally free, not even one of these fake free programs I give to patients all the time. It is a community as well as modules about higher fiber diets. And the whole part about a full plate is you can eat whatever you want, but can you get 75% of your plate to be whole high fiber foods and then 25% whatever you want, your meats, your sweets, your crackers, you get to pick. So it is totally free. And if you wanted to learn more, you can scan that or go to their website. And then nutritionfacts.org, that's the place that is coupled with that daily dozen worksheet that has a lot of blog posts or video modules, little podcasts that you wanted to learn something about specific, like if you've got a specific cardiovascular disease question, or even not, irritable bowel syndrome question, what have you, it's a wealth of resources. So with that, I know it's 12:49, but I'm happy to take any questions or comments.
For a round of applause. Just very quick announcements, and then we'll get to questions because I had some come in and some comments. In a couple minutes, or I guess we can flip to it now. This is the eval. So if you have a phone, want to pull it out, get the camera on, go to the QR code. You can do the evaluation now. Let us know how you liked today, what you want to see. If there's future topics you want to see, future speakers you want, please put them in there. We want to make sure that we are making these for you all and what you want. So do that. I will also send it out in an email if you don't want to do it now, don't know how to do a QR code. We'll make sure you get the link in an email. Before we get to audience questions, one comment that made me chuckle and I relate to was when you were talking about NEAT. They said it makes them feel better about swiveling their chair during Zoom meetings. And I relate to that. I'm constantly swiveling back and forth. So I had to share that one. And then there was a question that was emailed to me. And they ask, for people who have multiple disabilities that limits physical activity due to unexplained and debilitating pain, including not being able to walk or stand very long, having limited upper body movement, not being able to exercise, is there anything that they can do as an alternative to exercise if that's what's best for good heart health?
Yeah, so great question. I think often about, people who don't have the same abilities I do to walk, for example, 3 times a day. And so I think working with your healthcare team and your physical therapist for what you can do. And then part of it is, I think, a little bit of like calorie, nutrient, energy, activity, like mismatch. So, I know on days that I don't exercise and that I'm sitting in a lot of Zoom meetings, I really don't need to eat the same as the days that I have been very active. And so, just making sure that you're getting a high nutrient dense diet. And then if there are any activities you can do to get any movement, whether that be hand, arm, neck, toe movement, like anything matters. And so, but you might need to work with your physical therapist or specialist on that.
Great, thank you. Were there any questions? I thought I saw a hand go up as I was coming up here, but does anybody have any questions? All right, I'm going to run you the mic. I'm going to walk it. I'm not going to try to run.
Actually, right now, there are a lot of supplements available. Do you have any comments about that? And another question is that very, very specific question that right now, the supplement called red yeast rice. Yeah, that's for tackling the high cholesterol.
Mm-hmm.
I just would like to know how your comments about those supplements.
Yeah, thank you. I think the supplements are tricky. One, because they're not regulated. So you never quite know what you're getting unless they are third-party tested. I've heard of red yeast rice, but I haven't looked at the most recent data. And if there's concerns about contamination or how effective it is, I don't see a lot of cardiologists or even sort of nutritionally minded people recommending it necessarily. The one that's most commonly asked about is an omega-3 supplement if you don't get enough in your diet. Either through fish, walnuts, chia seeds, et cetera. And so again, I don't think we have enough data to like hard endpoints to say like everyone should be on omega-3 supplement. However, it's probably low risk if you can find it like sourced in a way that is non-toxic and you actually know what you're getting. And that's, again, the trickiest part. So I mostly tell patients and sort of in my family, like until we nail the basics, like the supplements are a drop in the bucket. So focus on that first. And we do have really good medications for things like cholesterol. And so the question is like, would you do red yeast rice instead? It's a conversation I would have, but I will see what I can find as far as data on that and I'll email it to Nicole.
Any other questions? Don't see any here. Let me check online real quick.
Okay.
All right, last call.
So when you say When you
Yeah.
say third-party tested, is that like indicated on the bottle? Is there a good?
There are a good couple companies, USP, so it'll have that USP label, or GMP, it stands for Good Manufacturing Practices. So I think either of those are relatively equivalent, but look for those for anything that you buy, for sure. Mhm.
I don't see any more hands. I don't see any questions online. If something comes up, feel free to reach out. I know your contact information was in there. It's in the slide deck. We'll be hanging around afterwards. So thank you so much, Dr. Tartaglia, for being here today. This was a fantastic presentation, so informative and helpful and fun. And thank you to everybody who attended online, in person. We appreciate it, and we hope to see you at some of our future events. Have a great day and weekend.
Thank you. Get in touch if you have any questions or any comments, and take the long way back to your office. It's for your